Does taking estrogen therapy for menopausal hormone symptoms increase your risk for stroke? All right, guys, we're going to go ahead and break down the science regarding menopause hormone replacement therapy. This is estrogen with or without progestin and the increased risk of stroke. We're going to get into the weeds of the research. In my last video, I was talking about menopausal hormone therapy and the increased risk of heart disease. So check out that video and give me a like and subscribe. So let's jump in to our topic for today. We're going to talk about menopausal hormone therapy and stroke. Does menopausal hormone therapy increase the risk of stroke? What happens to people who've already had stroke? What about people who've had other medical conditions? So why does stroke risk matter? Stroke is the leading cause of disability in women, and they actually experience more strokes across their lifespan than men. We face a unique decision point around menopause on whether or not to prescribe treatment for menopausal hormone therapy. But the early relationship between estrogen therapy and a stroke has been confusing. Some studies showed that there was a benefit to stroke. Others showed there wasn't any, and some even showed that there was a slight increase in the risk of stroke. Before clinical trials, several population studies looked at estrogen use and stroke risks, and the results were all over the place. In the NANE study, they found a significant reduction of stroke risk with estrogen therapy after adjusting for the other risk factors. Shortly after, a very large study looked at patients and matched them with age controls, and they found that those who took the estrogen compared to those who didn't take the estrogen didn't have any net benefit. Other data showed that any increase was mostly seen in the first 6 months of therapy. And then the renowned Nurses' Health study actually found a slight increase in stroke risk with long-term estrogen therapy. Why was this inconsistent? Well, it's because most of those earlier studies were observational. They couldn't truly understand and control for all the different various effects and factors that come into play when it comes to these types of studies. They couldn't control for socioeconomic status or those that were seeking healthy habits and treatments for their symptoms, which usually tend to be women who are healthier and wealthier. So that skewed the results. This is why a randomized trial was needed. I've talked about the importance of having randomized prospective studies where participants are blinded, where researchers are blinded, where you have control groups, you have the group of patients who's getting the new treatment or test or new dose compared to those who aren't, to really get a good, vigorously studied result. But most of the time, we don't have that. Once randomized trials entered the picture, there was a more clear representation of what was going on. And in short, oral estrogen therapy does increase stroke risk. So let's break down the trials. We have the very famous HERS-1, which stands for Heart and Estrogen Progestin Replacement Study. This trial looked at women with known coronary artery disease. They've had known heart disease, and they gave them estrogen and compared them with women who didn't. And they found that there was a risk toward higher risk of fatal stroke with estrogen therapy. The risk was actually 61% high, and it was close to statistical significance. In the West trial, this one included 664 postmenopausal women with prior stroke or mini stroke. They gave them estrogen, estradiol at 1 milligrams per day, and they found that it did not reduce their risk of having a stroke again or death. It actually increased their risk of fatal stroke. They told us that estrogen did not prevent strokes and might make the worst ones even more fatal. In the Women's Health Initiative, one of the most popular and well-known studies in recent times, it included thousands of healthy postmenopausal women, and they found 31% increase in the overall stroke risk with combined estrogen and progestin. The key points from the Women's Health Initiative were the following. The risk became evident between 1 to 2 years of starting therapy. The risk increased in all age groups, even the younger ones. And in the Women's Health Initiative trial of the estrogen by itself, the stroke risk was also significantly increased. They found that the excess risk was similar whether or not a woman had a previous stroke. When both the Women's Health Initiative menopausal hormone therapy treatments were looked at, they found a hazard ratio of 1.32, which meant that there wasn't any meaningful difference by age or time of menopause, but that there was an increased risk of stroke. Women aged 50 to 59 had a lower baseline risk, so their absolute risk was small, but even that group had an increased risk of stroke. The overall numbers of strokes seen in that group were small just because younger women have less stroke in general, but they found an increase in them. A meta-analysis was performed of all the major trials. They combined the HERS, the WEST, the Women's Health Initiative, and other meta-analysis. And they found, in short, that there was an increased risk of stroke, the non-bleeding kind, ischemic stroke. There was no increase in the bleeding or hemorrhagic stroke. And there was a trend toward higher fatal stroke risk. So this is the best overall summary I have for you. Oral estrogen has been associated with an increased risk of ischemic stroke by up to around 30%. Now, what about the type of estrogen? Does oral versus transdermal patch make a difference? Well, that's what the evidence shows. Estrogen patches might be safer than the pill, especially if it's at a low dose. A large population-based study with controls, around 16,000 strokes and 60,000 people were matched as controls, showed that low-dose estrogen patches, what we call transdermal, of 50 micrograms or less showed no significant increase in stroke. The high-dose patches that were greater than 50 micrograms did show an increased risk of stroke. Oral estrogen was also looked at and increased the risk of stroke across the board in terms of dose. This is why many menopausal experts will recommend starting with a low-dose transdermal or estrogen patch. Avoid the high-dose patches unless it's absolutely necessary, and they use the lowest effective dose for the shortest time. But why would oral estrogen have a higher risk of stroke? We've already talked about the benefits of estrogen in a previous video in terms of raising HDL, lowering LDL, but estrogen has been linked with raising inflammatory markers such as CRP, clotting factors, and estrogen can also increase triglycerides. All of these factors contribute to plaque buildup, which can cause problems all over the body, from strokes, mini strokes, heart attacks, and the like. And then transdermal estrogen bypasses the liver, giving it a more stable metabolic profile, hence the lower risk. So there may be a mechanism of play there. What does this mean for you? If you are facing the situation of whether or not to take estrogen, you and your physician will engage in shared decision making. They're going to factor in your personal health profile, your history of stroke, or your risk factors for having a stroke if you've never had one. They'll look at your family history, your medical problems, your social history, alcohol use, cholesterol, and many other things in order to reach a decision and make the best advice to you. If you do decide to take estrogen, low-dose transdermal estrogen might be the safest route, especially the dose that's 50 micrograms or less. High-dose patches increase the risk, but the dose matters. Age does not eliminate the risk. Just because you're between the age of 50 and 59, your stroke risk doesn't necessarily decrease, although it may be less than your older counterparts. And then last but not least, I like to focus on lifestyle factors, which do make a difference. We're talking about cutting the smoking, focusing on the cholesterol, and we're talking about raising HDL, lowering LDL, lowering triglycerides. All these lifestyle changes make a difference. So the final takeaway is this. Estrogen therapy can dramatically improve hot flashes, sleep, mood, and the quality of life. But the scientific evidence is clear. The route, the dose, your age, your medical history, all come into play when it comes to making a decision about which type of estrogen and whether or not estrogen therapy is safe for you. Talk with your doctor. In my next video, I'm going to talk about the relationship between hormone replacement therapy and venous thromboembolism, so stay tuned.